Hey everybody! Welcome to week 3 of Physiological Psychology here from Dr. Kirby's living room. Let's get started talking about plasticity of the brain and maybe some issues that can come up through development. We're continuing this piecemeal approach of looking at chunks of a few different chapters out of order from the way they're published in the book. And that's because, again, I like starting with that bigger picture view before we zoom in on teeny tiny things like how a neuron works. So now that we've learned parts of the brain and how the brain develops and how the rest of the nervous system develops, now let's look more at plasticity of the brain. So once it's developed in an adult, how does it change with experience? And how could those changes go differently to create neurodevelopmental disorders? Okay, so for this week, you need to read modules 4.3. That one is about plasticity. 14.3 is about schizophrenia, and 14.4 is about autism spectrum disorders. You also need to complete the second collaborative quiz and prep guide 2. So let's start with plasticity after brain damage. We're going to talk about stroke recovery and the phantom limb phenomenon and what that actually looks like in the brain. So there are two different types of strokes we will talk about in this class. One is an ischemic stroke, which is a blockage. It's sort of like the same stuff that happens for a blood clot somewhere in your body, for a heart attack, for a pulmonary embolism. These types of blockages can happen anywhere in your body. When it happens in the brain, there's some kind of buildup that prevents blood from actually passing through one of your blood vessels. When it happens in the brain, we call it a stroke, and this specifically is an ischemic stroke. A hemorrhagic stroke is a different type where you have a blood vessel that bursts, maybe because of buildup behind one of these ischemic blockages, but whatever the reason, you have a hemorrhagic stroke, which is where, hemorrhage means like bleeding extremely heavily. So hemorrhagic stroke is when your blood vessel breaks and you have lots of bleeding. So in an ischemic stroke, the idea is we need to stop the clot quickly. If it was a hemorrhagic stroke, we would need to promote clotting to stop the bleeding so that your blood vessel could quickly repair itself and close. Because either way, you're going to have brain damage. In an ischemic stroke, what happens is the areas that blood vessel normally feeds, those neurons and glia starve and die. And then in a hemorrhagic stroke, they actually get flooded with too many of certain compounds and salts, and they die from toxicity. So they get poisoned from the extra blood spilling out into the brain in a hemorrhagic stroke. An ischemic stroke could be a variety of different severities. Everybody's blood vessels in their brains are in different places. And so it's a little bit unpredictable sometimes to know how well somebody could recover from a stroke. Or how much initial damage is even going to happen because of the location and how that's highly individual. But many ischemic strokes can be very survivable and you can have quite a bit of recovery. In hemorrhagic strokes, however, those tend to be much more dangerous. There's not really treatments that can help you very much if you have a hemorrhagic stroke in a lot of cases, and so it's much more likely to result in death. There's not as much we can do about these. Stroke treatment needs to be very quick and immediate to prevent most of the long-term effects. Now, there are longer-term treatments we need to look at, but in the short term, you need to remove that blockage with blood thinners in an ischemic stroke. Okay, so when somebody comes into an emergency room with stroke symptoms, many times there's not time to do the types of scans it would take to figure out which type of stroke it is. Ischemic strokes are far more common. They are more treatable. You have blood thinners around like tissue plasminogen activator, TPA, which can break up that clot. And so if, let's say, 75% or more of the strokes that you see are probably going to be ischemic, you probably couldn't do anything for a hemorrhagic stroke victim anyway. What some hospitals do is just go ahead and make that judgment call. It's a little bit of a gamble, but it's one with a lot of evidence behind it. They tend to treat anybody with stroke symptoms as if they're having an ischemic stroke. And let's think about what this would do. In an ischemic stroke, that could help the clot break up, help the blood flow resume, help prevent many of those brain areas from dying. You get very early treatment and you're going to bounce back a whole lot easier this way. In a hemorrhagic stroke, on the other hand, if somebody gave you a blood thinner like TPA, it would make the bleeding worse. The person might die anyway if they're having a hemorrhagic stroke. We don't know how to quickly find out in many cases. And so it's sort of the greater good kind of decision to treat it as if it's ischemic when people come in, because you could have the potential to greatly improve somebody's life versus you don't really have a way to help somebody who might have had the other type of stroke anyway. You might speed things up, but it wasn't going to change the outcome much. So this isn't the case for all hospitals. This is just a procedure that your textbook author talks about. So I'm not trying to say that anybody is doing it wrong or that you have wrong information if you work at a hospital and you know otherwise, or if there are other treatments for hemorrhagic strokes or quick scans that you could do to figure out the differences between these. I am not a medical professional, so I know this from your textbooks information. If you're a nursing student and you know better than me, good for you, and I would love to know more about how this works so I could update my teaching materials in the future. So that's the immediate treatment for a stroke.